So understanding your background affects your risk. And so, yeah, please do get checked.
You mentioned ultrasounds. I guess, and this is going to be, I think, beneficial for all three of the members of the panel in front of me now to address. You know, how much is new digital technology and ultrasounds and CATs and MRIs and that kind of thing. I think Dr. Berg got a big 64, 120 slice toaster over at his place that can see around corners. I mean, how beneficial is that to your investigations for lung and liver and pancreatic cancer and prostate cancer?
Well, in lung cancer, the big study that was just reported compared CT scans to chest x-rays. Chest x-rays had been tested back in the 70s at Sloan Kettering and Hopkins and Mayo, and really were not useful in detecting lung cancer early. Well, CT scans are a major advance forward, and CT scanning is becoming better, more sensitive, more specific, lower doses of radiation exposure to patients. So the future of CT scanning to screen for lung cancer is going to get better and better.
Okay. Doc?
So for liver cancer, ultrasound as a surveillance tool is really what we're using. If you have cirrhosis, you should get an ultrasound every 6 months to look for development of cancer. If you have the diagnosis of cancer, then MRI and CT are critical. Ultrasound really isn't good enough at that point in time.
It's not high enough resolution?
Yeah, not accurate enough in terms of blood vessel involvement and that sort of thing.
Dr. Shea has got a 4D ultrasound. Is it? Are they? When I know that the gynecologist and pancreatic cancer guy, but I mean, are there similarities when you're talking about that third dimension?
The key with ultrasound is to make sure that if you're using it as a surveillance tool for liver cancer, that it's part of an overall program, that you have a reliable facility that's going to perform it. We at our center will actually alternate ultrasound with either CT or MRI because we're not quite as confident that ultrasound is adequate. But there's plenty of centers and plenty of data that if you have a reliable ultrasound facility, that's perfectly fine.
What's your favorite tool in the box?
So the thing that's all the rage in prostate cancer right now is actually MRI. And at Cedars and several places in the States, we can actually do MRIs now without the use of an endorectal probe, and that's pretty much what it sounds like. Before, to get the best images of the prostate gland, we had to put the magnet right up against the prostate gland. But now that the magnets are stronger, we can get amazing resolution of the prostate gland, and we have some of the best imaging scientists that I've met in the country working with us, and they're actually able to come up with different sequences that help us to highlight certain areas that look like they're high risk. We can even fuse those images to ultrasound images now in order to optimize our biopsy approaches, and Dr. Hyung Kim, our head of academic urology at Cedars, is using that to really target his needle biopsies to get the very highest yield information from a procedure. And I think that's going to be a more standard part of how we care for men with prostate cancer in the next 5 years.
Is there another technology that's around the corner that you guys are excited about?
Positron emission testing, PET scanning, is one that a lot of people ask us about. Ron's doing some research with certain forms of PET, but in prostate cancer, we're using PET scans now to look at the bone with high resolution, and we can even track the places that hormones go. There's a way of labeling testosterone to see what parts of the body it goes to, and that's a sign to us when there's overaccumulation that there may be a prostate cancer hiding somewhere in that part of the body.
I'm gonna swing by and get another explanation of that. I said, Doc, give me the Cliff Notes version of what Ed said.
First of all, I want to point out that you've heard some amazing facts this morning in conversations from the docs that are here. And I think we have to recognize that Tom Shea and Guam Medical Association and Cedars Sinai in combination have been putting on this annual symposium. And this is, I guess, the third year we're collaborating. And this is a world-class symposium. So here we are on Guam, middle of South Pacific, and putting on a meeting that is excellent in any from any standard, and could be held in any city in the world, and would be recognized as being excellent. And we're missing one person from our group here. Evan Zahn is here with us. Evan is a pediatric cardiologist, and he has started the congenital heart program at Cedars Sinai. So when we think of congenital heart disease, we just think of little babies that just were born and have to have some corrective surgery. And there are a lot of kids who have survived that surgery and then go on to become adults. Well, a lot of the corrective surgery that was done when they were little kids is kind of getting too small when they're adults. So the program that we have not only takes care of little kids with congenital heart disease, but takes care of adults who have survived some surgical procedures. and they specialize in the minimally invasive approach, which is, I think, something we're trying to do in all of our surgical specialties. So I think you'll hear, in addition to Ron and Nick and Ed, at the symposium, you'll hear what Evan has to say about the latest and greatest.
Yeah, we're scratching the surface. They're deep scratches, but we're definitely talking about some surface stuff. People in the medical community will be asking, I'm sure, broader and more intelligent conversations. I happen to be the layman out there and try to get things to a point where if I can explain them to you, I think we've got it. Jim's on the line, and Jim wanted